In this lecture, we will learn about hypoxic ischemic encephalopathy of the neonate. So we'll discuss about the definition, causes, clinical features, the complications and the management. Hypoxic ischemic encephalopathy. What does it mean to you? Hypoxia. That means lack of oxygen. Ischemia. Lack of blood flow. Encephalopathy, features of malfunction of the brain. So, which means poor function of the brain due to lack of blood flow and lack of oxygen supply into the neonate. So, that's the general idea that a medical student should have regarding hypoxic ischemic encephalopathy. Now, when we go to the definition, it's a heterogenic, clinically defined syndrome. We haven't got any biochemical markers or investigations to confirm the diagnosis as such. We go clinically. And this is characterized by disturbed neurologic function. That's your encephalopathy in the earliest days of life as a neonate. Typically in an infant born at or beyond 35 weeks of gestation. So the features indicate the disturbed neurologic function. So that is altered level of consciousness or presence of seizures, difficulty in initiating or maintaining the respiration, and also reduction in the tone of the neonate and also the newborn primitive reflexes. When we look at the etiology reflects causes that produce hypoxia and ischemia. If you take, for example, cord prolapse, uterine rupture, placental abruption, acute maternal hemorrhage, all these conditions abruptly reduce or stop the blood flow from the placenta into the fetus, leading to HIE. Amniotic fluid embolism, maternal shock are conditions where the mother can go into hypotension and therefore this impairs the perfusion of the fetus. Acute neonatal hemorrhage, such as a feto-maternal hemorrhage. The best example is our placental abruption. Again, there is lack of blood flow into the fetal brain and the neonatal sepsis. All these conditions predisposes babies to develop HIE. Let's see what happens during this whole process. So there's a primary energy failure which happens within minutes of birth, and then a latent phase which happens up to 6 hours of birth, and the secondary energy failure later on. So immediately around the time of birth, when there is cessation of blood flow to the brain, this reduces the oxygen supply as well as the glucose supply to the brain. So what happens? There is reduction in the ATP production and increase in the anaerobic metabolism compared to aerobic metabolism. When there is more and more anaerobic metabolism happening, what happens is the lactate accumulates, leading to acidosis. So this lack of ATP leads to sodium-potassium pump failure. So sodium as well as water gets into the brain cells, leading to edema. This leads to damage of the cells and release of excitatory chemicals, excitotoxicity, excitatory chemicals such as glutamate. And this promotes entry of calcium into the cells. And this is what is leading to necrosis and apoptosis. So the cells undergo death, cell death. This happens within minutes. So as soon as the baby gets this reduction in the cerebral blood flow, within minutes, this episode happens. So as the pediatric team, there's nothing that we can do around this point. But then the baby gives us a window of opportunity at the latent phase, which starts from about 1 to 6 hours after the birth, when there is reperfusion. So reperfusion is when the cerebral blood flow is restored. Now the brain is again getting some perfusion. So what happens is during this time with excitotoxic effects and the oxidative stress, if we do not intervene, the cell damage can worsen or continue. So this is where we intervene and do the therapeutic modalities to prevent the injury happening to the brain that we will be discussing later. And finally, the baby goes into secondary energy failure with secondary mitochondrial failure, and that's when they develop seizures and cell death. This happens after 6 hours. So let's see how these babies present. So in the delivery room, they will appear depressed at birth. So they don't cry, they appear floppy, blue or pale. And then the pediatric team or the neonatology team has to help the baby at the birth with resuscitation. In the postnatal period, you can see abnormal state of consciousness. That means it's very difficult to determine whether the newborn's conscious level. But a healthy newborn is alert, looks around, looks for a feed, and then there are the periods that the baby sleeps, and then there are periods that the baby is awake and crying. So those are the normal state of consciousness in a newborn. But if the baby is persistently lethargic, sleepy, not waking up for a feed, that's an abnormal state of consciousness. A newborn has got symmetrical, good movements involving all 4 limbs with good tone. When there's encephalopathy, we can observe diminished spontaneous movements. So they have respiratory difficulties, they cannot suckle very well, the tone is less, they have abnormal posturing. And when it comes to neonates, we don't talk about the tendon reflexes, but we talk about primitive reflexes. What are primitive reflexes in a neonate? Sucking reflex, rootling reflex, Morose reflex. Those presence of primitive reflexes indicates good neurological status in a baby. But when there is encephalopathy, these reflexes are absent. And then seizures are a feature of encephalopathy in neonates. So the HIE status is actually classified according to the severity. So as medical undergraduates, you don't have to know the details. Just remember that the presentation is quite variable, and there's a classification from stage 1, that's mild presentation, into stage 3, severe presentation. So they again use the same parameters that we used before in the previous slide to describe the presentation. The level of consciousness. See, initially in the mild stages they look hyper alert. The lethargic appearance, stuporous appearance occurs in the severe stages. Then we discussed about the tone, posture, and the reflexes. So you can see that in the mild stage, the tone, posture are generally normal, but in stage 2 and stage 3, they are getting hypotonia. Neonatal reflexes in the mild stage could be either weak, normal, but in moderate stages, they are weak, and in the 3rd stage or severe stage, they are absent. We can also look at the autonomic function with the pupils and the heart rate. In mild degrees, they have mydriasis and tachycardia, whereas in severe cases, in moderate cases, they can have meiosis, parasympathetic activity, meiosis, and then in severe stages, very variable. unequal pupils, poor right reflex, and the heart rate could also be variable. Seizures are a sign of either moderate HIE or severe HIE. You don't get seizures in the mild stages. As a pediatric house officer, your responsibility is not to miss a baby with HIE who will need intervention. Now, you will be attending deliveries and you will be resuscitating babies as a pediatric house officer. After you had to resuscitate a baby and you have been successful, the first question you are going to ask yourself is whether this baby needs further treatment, whether this baby is having HIE features. So to diagnose HIE features, we have already discussed that it's a clinical entity. So we have to look at the baby's condition. So we look at the history, cord, and the ABGA score, need for resuscitation. All babies who need resuscitation, you have to do a blood gas, which could be a cord venous gas or a capillary gas, which gives us the severity of the acidosis, indicated by a very low pH or a base deficit. And then we look at the criteria for cooling. Cooling is the specific management that we provide for babies with HIE grade 2 or 3 to improve their outcome as well as survival. Not all babies with hypoxic ischemic encephalopathy needs cooling. There are specific criteria, and at your stage, you don't have to remember these criteria. All you have to remember is that following resuscitation, you have to discuss with your seniors whether this baby needs to be admitted, how this baby should be monitored, and whether this baby fulfills criteria for cooling. Now, before we discuss about the complications of HIE, the management of HIE, let's go through the complications, because then we know how to work out the management. So we obviously know they can develop encephalopathy, seizures. So think about all the pathologies that can happen to each and every organ system due to lack of oxygen or lack of blood flow, lack of blood. Kidneys, ischemia leads to acute kidney injury. They can get coagulopathy, DIC. Sudden hypoxia leads to increased pulmonary vascular resistance. We call it persistent pulmonary hypertension. The liver undergoes ischemia. So the ASTs, ALTs rise, and this leads to coagulopathy as well. The bone marrow gets suppressed, leading to thrombocytopenia, and there could be a lot of metabolic abnormalities which happen due to the whole process. Now let's go through the management. Initial assessment is vital. Once we recognize that this baby is having hypoxia, ischemia, encephalopathy, so that means there is a baby who was depressed at birth, needed resuscitation, the cord gases showed acidosis, and the baby's ABGA is low, and then you assessed clinically. You could demonstrate the altered conscious level, you could demonstrate the hypotonia, diminished neonatal reflexes, and plus or minus presence of seizures. So with that, you admit the baby to the NICU and then you start the assessment. So these babies will need a partial septic screening, needing full blood count, CRP, and a blood culture. They have to be on continuous EEG monitoring. We call it amplitude integrated EEG. We have to perform the ultrasound brain to look at any hemorrhages. liver function tests, renal function tests, clotting, blood gas, and then careful monitoring of the blood sugar is a must. Going into the specific management, this is therapeutic hypothermia. You can see that the body of the baby is wrapped in a blanket. So this is cooling. Cooling is where we try to reduce the core body temperature into somewhere around 24 degrees and maintain that level up to 72 hours. Can you remember we discussed about reperfusion injury, which happens around starting from about 1 hour of age, 1 to 6 hours of age. We are using this window to start the cooling of the baby, to reduce the metabolic rate around this time, to diminish further injury happening. So we cool babies for good 72 hours. This is the amplitude integrated EEG that you can see. When we apply it, you can see probes are being connected to the baby's scalp. And the brain activity is recorded as amplitude integrated EEGs. This will give us an idea about the brain activity as well as the presence of seizures. Careful management of fluids is a must. Now remember, these babies, they can have acute kidney injury. At the same time, their myocardium could also be hypoxic. Therefore, we cannot overload these babies with hypoxia ischemia. Generally, all the other newborns who are admitted to neonatal units are commenced on IV fluids of about 60 milliliters per kg per day on the first day of life. But in babies with HIE, we use lesser amounts like 40 milliliters per kg per day. And other neonates who are not having HIE, we don't add electrolytes on the first day. But for HIE babies, we have to supplement with calcium from the first day of life. These babies cannot suckle milk from the mother because they are neurologically depressed. Therefore, you will have to provide expressed mother's milk via an NG or an orogastric tube. Antibiotics are indicated until we exclude an infection. Although in other neonates, the first line antibiotic for sepsis is benzyl penicillin and gentamicin due to the nephrotoxicity associated with gentamicin. We will not be using it during HIE. Therefore, for HIE babies, the recommendation is to start benzyl penicillin and cefotaxime. Cardiovascular status should be regularly monitored with the heart rate, perfusion, pulse volume, and the blood pressure. Whenever there is poor perfusion, babies will need inotropic support. We already know that they can develop coagulopathy. So if there are bleeding manifestations, they will need correction with blood and blood products. Throughout this process, mothers need counseling, and the situation of the baby has to be, the mother should be educated regarding the situation of the baby and the further management plan. Mother should be supported throughout. So we will be cooling the babies for good 72 hours, and after that we start slowly rewarming. That is at about 0.5 Celsius per hour. We will be slowly rewarming them back to the body temperature. Those who are having difficulty in breathing and maintaining respiration will need respiratory support in the form of either non-invasive ventilation with CPAP high flow or invasive mechanical ventilation depending on the severity of the respiratory problem. Even though these babies recover during the initial stage with intensive care, they can have lot of long-term complications. They can develop cerebral palsy, epilepsy, corticovisual blindness, sensory neural hearing loss, and also learning disability and behavioral issues. So the follow-up should be arranged keeping in mind all these complications that these babies can develop in the initial period. So we need to have an MDT or multidisciplinary team approach where they are looked after not only by a pediatrician but also involvement of a neurologist, speech therapist, occupational therapist, physiotherapist, and also depending on other problems the babies get, you might have to involve the other categories of staff as well. So the rehabilitation should commence very early in the process, ideally in the NICU setup per se. We are not going to wait until the baby develops features of cerebral palsy to start or commence rehabilitation. So the positioning and the movements, the visual stimulation, they will be commenced even when the baby is in the NICU along with the mother's support, and they will be carefully followed up by both the pediatric team as well as the MDT team, following up, monitoring their development, tone, OFC, and ensuring that their milestones are reached and appropriate help and rehabilitation is provided. Growth has to be carefully monitored in the well baby clinic. So regular measurements of the weight, length as well as occipitofrontal circumference is a must. And then you need to arrange for hearing advanced testing and also for vision assessment, as these babies can develop corticovisual blindness. So now we have learned the principles of management of hypoxic ischemic encephalopathy, and we have come to the end of this lecture. So remember, early recognition is critical in HIE. So as a house officer, it will be your responsibility to think and ask yourself after resuscitating a neonate whether this baby is having hypoxic ischemic encephalopathy. Do I have to initiate therapy, specific therapy for that? We know therapeutic hypothermia saves brains, improves outcomes. However, this has to be started within the first 6 hours of birth. That is why early and timely recognition is critical. When we delay identification, we delay the commencement of therapeutic hypothermia, then the effect is going to be less. We know that HIE has got lifelong consequences. Therefore, long-term follow-up is necessary. However, remember, most of these HIE cases could be prevented. So prevention is the main thing. Thank you.